There are a number of factors which might influence the timing of an athlete's return to competitive football. These include a. Risk and reward analysis. For example, it is the finals, the athlete's return may be expedited, however, the risk of re-injury may be increased. b. Individual's current athletic and previous injury profile. Has the athlete done all that has been asked of him/her and progressed through all levels of the rehabilitation, return to running and return to sport, appropriately? Is this the first time the athlete has incurred this injury? c. Individual's goals. Is the player a rookie or a senior player? What phase of the season is the athlete returning to play? d. Individual's position. An athlete must pass all fitness criteria specific to his or her position. For example, a striker is going to require a different level of cardiovascular fitness than a goalkeeper. e. Time of season and ground. As stated previously, the time of the season can play a role in how rehabilitation is structured, as can the condition of the ground the athlete will be training or playing on. Adjunctive therapies. There are a variety of other therapies that have been described that may assist with the healing of bone stress injuries. In general terms, the evidence for each of these is lacking. While they may be added to a treatment plan, the key strategy is relative rest. These treatments should not detract from this key principle. Bisphosphonates block bone resorption by binding to hydroxyapatite crystals in bone and may stop dissolution of the matrix by osteoclasts. This may allow the balance of bone resorption and formation to tip in favor of new bone formation. Bisphosphonate treatment for stress fractures in young female athletes with female athlete triad disorders is not established, and there is little evidence for its effectiveness in the literature. Bisphosphonates have concerns of teratogenicity in childbearing women and are not approved by the Federal Drug Authority, FDA, for increasing bone mineral density or fracture risk reduction in young or adult athletes. If bisphosphonate treatment is considered, then the patient should be referred to an endocrinologist and treatment started in conjunction with this specialist. The combined oral contraceptive pill is often prescribed to women who are thought to have developed a stress fracture in association with relative energy deficit, RED-S. The rationale is that the additional estrogen may improve bone mineral density. The evidence for this is lacking, however. The OCP does not restore spontaneous menstruation, and can create a false sense of security as a withdrawal bleed occurs monthly. Research has demonstrated that combination pills are not an effective strategy to increase bone mineral density in low-weight conditions. The contraceptive pill does not normalize metabolic factors impairing bone health and so is unlikely to reverse low bone mineral density in an athlete with RED-S. 9 Pharmacological therapy with estrogen replacement may be considered if there is failure of non-pharmacological management after 1 year, and persistent low BMD scores on DEXA testing. However, the research is inconclusive with regard to the benefit of combined oral contraceptive therapy, with the majority of studies suggesting that oral contraceptive treatment is not effective in increasing bone mineral density or reducing stress fractures. Adequate analgesia is obviously important.